I welcome you all here. I am Jessie Torrey, the proud mother of Jack Torrey, who celebrates 19 years post-transplant on Saturday. I also have ALD, as does my mother. And we are so fortunate today to welcome Dr. Torri Jones. And let me share a little bit about her. Dr. Jones is a pediatric psychologist embedded in the cellular transplant and therapy section of the Division of Oncology at the Children's Hospital of Philadelphia, CHOP, an associate professor of clinical psychiatry at the University of Pennsylvania Perelman School of Medicine. Areas of clinical expertise include behavioral modification, pediatric blood and marrow transplant, immunotherapy, palliative care, and health equity. Her research program identifies and addresses psychosocial risk factors, supports family-centered intervention, and promotes medical adherence. Findings have been published and presented at national and international scientific meetings. Dr. Jones serves as a member of the CHOP Training Advisory Committee to design student programming and support pre- and postdoctoral development, and earned a Teacher of the Year award. I was so impressed to hear that. For excellence in teaching and mentorship. She is also a member of the CHOP BMT Supportive Care Committee to improve staff communication, workflow, safety, and the patient and family experience. She is a member of the Society of Pediatric Psychology, the International Society of Pediatric Oncology, and the Multi-International Association of Supportive Care in Cancer. Prior to coming to CHOP, Dr. Jones held psychologist licenses, medical staff appointments, and leadership roles at other hospitals, university, and community settings, serving patients and families, and teaching psychology trainees in English and in Spanish. I'd like to welcome you, and I have had the pleasure of meeting you several times, and folks, we are in for a great workshop today. Thank you.
That is so kind. Thank you so much, Jessie, as well as Kelly, for all of your help to get things started. And thank you very much for that wonderful introduction. I'm hoping if I'm doing things right today, I'm hoping that you'll be able to walk away with a couple strategies to keep in your pocket in order to help with ways to be connected and not consumed in the setting of moving through care. And I think that when we're moving through medical care, there's this expectation that we have to kind of be at all the things and know all of the facts. And I'm really hoping that we can illuminate a couple of alternatives today. And so ways that we might be able to operate as a community and not feel kind of overwhelmed in the setting of that. So just to give you an idea of where we're headed, I'd like to talk a bit about who's at risk, couple of things that we know about folks that may need more support versus folks that may need less support, and thinking a little bit carefully about what the driving factors are. And then I'd like to talk more about setting healthy limits. I'd like us to move into a conversation about ways that we can consider capacity, right? Like how much is available in each of these different domains, right? How emotionally, physically, interpersonally available can I be? And then also thinking carefully about access. So how much access do we offer to other folks, and how much of that is useful and productive for our own coping? And then thinking carefully about what that looks like for social media and for community support. And then we'd move into talking about building resilience. And I'd like to see if there are ways that we can use some metaphors to keep us kind of thinking about the way that we handle resilience in other areas of life and how we might map that on to how that works in the setting of care. So thinking about what the building blocks of resilience are, what the literature says out there in terms of ways that we can keep ourselves aware about how things are going in any given moment. And then what do we do when this is not a drill? How do we handle the process of managing unexpected curveballs? And then also, how do we think about assessing and adjusting our plans and our processes to see if they're still serving us well? And then, of course, we'll have an opportunity for questions. Okay, great. So let's move ourselves into who's at risk. I'm going to talk a little bit about some work that we've been doing at CHOP. So I'm going to present a couple of findings, but I'm going to try really hard to make that a little bit less than sort of academic and slightly boring. And I'm hoping to make it sound like it can fit well with how to understand what we would expect in terms of how people respond and react to diagnoses and longer courses of medical care and treatment. So what we know in the literature and what we know in science overall is this idea that we kind of have this expectation that people are going to be distressed about getting a diagnosis. People are going to have reactions, natural, genuine, honest reactions, responses to receiving diagnoses, receiving information about medical trajectories. I'm, again, the psychologist that works on the bone marrow transplant unit. So I have patients that I've seen with ALD and patients that I'm currently seeing that are out from transplant, and even those that are going through the process. And so I walk right into patient rooms and I work with folks while they're inpatient. And then I also see them outpatient where they're wearing their own clothes and they're kind of coming and going and being able to think about what it looks like to operate in that process after care or while outpatient care is happening. So when we do that, we have just a sort of a regular guideline for pediatric psychology that it's best practice to make sure that we're doing pretreatment screening. So what we do is we offer a number of different kinds of questions to families, and we ask, we keep that information and compare it to what other families are going through across the nation. And this measure, this particular couple of different measures that we use, helps us to gauge that. What we've learned is that definitely that universal tier on the bottom there is where most people are. So most folks have distress, right? Patients and families are feeling distress, but they're resilient. And so they often move forward in care with, you know, the support of social work, which is assigned to everyone, child life. Maybe they aren't needing additional supportive care in terms of other parts of the psychosocial team. Then we move into the targeted zone, the green zone there. And that's where folks are actually having more distress, and they also have risk factors that lead to having a more difficult experience. And then we move into the yellow zone at the top, the orange zone, and that's the place where folks are needing specific support, like a psychologist, a psychiatrist involved in their medical team in order to help them navigate through care. And so in our setting at CHOP, we've learned that our ratios are very similar, right? So we have the same kind of tiered approach as far as what we've recognized. Who are the folks that need the most help, and who are the folks that are, you know, dealing with this information and moving forward in a way that we think is adaptive or something that's not related to significant impairment or significant distress that's keeping them from living their lives. So distress and impairment are usually our big two determinants about whether or not a psychologist should be involved. So is it distressing? Does it bother you that it's happening? Is it impairing? Is it getting in the way of your regular daily life? This could be the anxiety or the depressive symptom or just the distress by itself about having to go through a course of care. So any of those things, even if it doesn't have a particular kind of fancy label, if someone is coping in a way that's not, that's getting in the way and that's bothersome to them, then we want to do something about it or be involved in order to think about care. So when we think about family distress over time, this is another model that we use, and it's really related to the one that we just saw, this idea of like what happens to distress and what happens to it over time. So certainly a person can get a diagnosis and then need to think, or this could be, you know, a particularly traumatic medical event or any kind of element of care that was significant. And so that big, you know, sort of sunburst there is, this is the thing, this is the event, this is the thing that's happened. And then folks on the blue line are typically going to, increase distress, it'll plateau, and then they'll either return to where they were in the first place by going down there, or they'll keep going straight at that plateau because they've been able to kind of figure out a way to navigate whatever their new normal looks like. The red line, though, is the line where distress is escalating or it's staying at a level that's more problematic. And that's what we want to be thinking about and focusing on. So I'm going to talk for just another moment, if you'll forgive my use of diathesis and a super kind of scientific term, but the idea is that we think of that word just to mean anything genetic, historical, biological that's a vulnerability, right? So something that predisposes somebody to have a certain kind of condition. And so some folks, right, are just kind of predisposed. You all know genetics like nobody's business. And so the idea that, there'd be sort of a certain predisposition that any different individual will have. On top of that, we layer in life stressors, big or small, any sort of amount of them. And you'll notice that there is certainly sort of person A is closer to the red line, even with a smaller amount of stress than person B, right? So in some cases, a person with a larger level of predisposition can experience a few things and then end up distressed in a way that really leads them to need some significant support. And then person B can have all kinds of life stressor on top of this smaller level of predisposition. And then that just leads to a different sort of trajectory, right? More stress can happen before they reach any sort of mental health threshold. So this applies to any kind of mood disorder, including depression. It applies to anxiety, including PTSD, anything along, like in that sort of whole class of concerns, any substance, eating, or psychotic disorder. All of those things are all sort of related to this particular type of model. So moving now into, well, what do we do about all that? And so how can we set healthy limits? What can we do on a daily basis in order to think carefully about managing the way that we interface and the way that we sort of manage the different issues that we're facing? So I'm going to talk a little bit about the spoon theory. And so I'm going to actually introduce a slide that looks like it's hidden, but I hope that you can still see it. It says, "What is spoon theory?" And this gives me a little bit of an opportunity to summarize all these tiny words on the screen, which is just that there was a person back in the early 2000s who had gone out to lunch with a friend. That person has a chronic illness, and the friend said, well, what's it like to have that particular chronic illness? And so what happened is that she actually got up, got some spoons from these unoccupied tables nearby, and she started handing them over to the friend, asking her to just sort of go through the day, like, tell me your routine. And every time that she gave her a different, oh, I did this in the day, I did that in the day, there just ended up being less, she'd kind of take a spoon. And so the idea was that you lose out on, you can kind of assign different values to these different activities or these different elements of the routine. And essentially, if you end up with 12 spoons for every given day, you really only have a certain amount available. And then each different kind of activity takes away its, sort of corresponding amount of spoons. And it started to get really fast. And so I started to think like, wow, just to execute these different, we're at lunchtime and you've lost, more than half of your spoons. Like, what does this mean? And what do you do? Like, can you get spoons back? Like, how do we figure this all out? And it actually is true that in this theory, there's this way that you can think, okay, well, if you sleep or if you do some sort of restorative kind of process that gives you a chance to replenish your battery, then you have this sense of getting more spoons back and being able to take on more things. But we think about this kind of thing in the setting of finance, right? We only have a certain amount in the bank and we can only do what we have. And so it's clear that we have this way of thinking about this in some parts of our brains. We don't always apply it to things like emotionality or behavior or coping and, sort of adjustment or management of the different stressors that we face in life. So I think the idea about, sort of approaching things thinking like, well, how many spoons do I have left and what can I take on? Can I participate in, a webinar today? Can I, take on a volunteer role that's going to require me to do a whole Saturday where we're getting the word out about ALD, and we're really trying to support the community's understanding and awareness about this particular condition. There are a number of different ways, right? If you are involved in all the things, at some point we run out of spoons. And so the hope is to be able to think really deliberately about how it is that we would want to use those in a way that helps to maintain that kind of overall capacity, right? And on some days, some things might weigh different. And so there might be a way that we just keep that in mind and figure out how we want to I think if we can be intentional about that, then I think it helps us be able to use what we have in a way that's meaningful and in a way that allocates the right amount of energy and effort to the things that we really need to prioritize. So this slide I'm going to get through without reading all the things. I'm just going to give this idea that these are a couple of different things to keep track of. Thinking very carefully about unsolicited advice and the kinds of things that people say when they are super well intentioned, but they end up kind of leaving more of a mark. We're going to talk a bit about toxic positivity soon. We're going to talk a little bit about a sandwich technique that might be a nice way to have a ready response in your back pocket to offer out kind of canned reactions to things that allow for you to stay true to who you are and the way that you like to interact with people, but also that preserve some boundaries and set some limits so that you're not, for example, giving someone level 10 out of 10 access if they're demonstrating that they can really only be level 3 responsible, right, for the way that you're interfacing and you're interacting with one another. And that each of those different thresholds can be different for different people or even for the same person in different circumstances, depending on how many spoons you have left, right? And so allowing ourselves to have permission to regulate things based on the data that's incoming, based on our own kind of assessment and self-awareness of like what's happening for me right now. And so thinking about intentionality, just the kind of, regular disclaimer that online is forever. So we often have families use Caring Bridge or other kinds of things. I have no particular affiliation with that particular sort of format, but there's this idea that if we have a lot of information about a child who doesn't get to make decisions about how much information of them is made available, if it's online on Facebook, for example, or if there's a way that it's in a place where when they're like 30, now they're looking back and realizing that there's a picture of them with an NG tube and they're sitting in the setting that, has that puts them in a position that maybe they're not excited about. Just thinking really specifically about, again, intentionality, who gets these updates, how much details provided, how often is this happening? And then once it's out on the interwebs, it sort of stays there. So keeping those things in mind when we think about, like, have I spent my whole day updating the family on what's happening? And can I do that a bit more efficiently? Or is there a way that I can regulate so that every Friday they expect a message from me? Or, some way of trying to be able to preserve a bit more of, sort of the space that a caregiver needs to be able to do the caregiving role, but then also to be able to be available to the people who are in the community that want to support. So I want to kind of keep going. I'm happy to come back to any of this, but I want to keep going so that we can cover a bit more ground. But one of the things that we want to try and be really careful with is this idea of information seeking as coping. And so, of course, if we can get all the information that we can possibly gather, then we can be able to feel fortified, right, against the curveballs or the unexpected things. And unfortunately, we don't have the ability to get all the information, and we want to rely on the medical team for the things that they can offer. And there's a way that sometimes that search, right, that pursuit of information can be pretty traumatizing. And so just thinking really carefully about just regulating and balancing along the way, I think are the things that we really want to highlight. So can you help others get their needs met, but then also be aware of when and whether your own needs are also being met, right? And being able to really regulate that. Okay, so let's head into toxic positivity. I'm sure that we can imagine a time when there might have been, information offered that has been, I'm sure we can identify with maybe two, if not three, if not all of these different phrases that we've heard at some point in life. And I know that as humans, we want to show compassion. We want to be really careful to acknowledge what folks are going through and say the right thing. And there are many, many ways that folks can kind of say things that they're thinking are helpful and that don't end up actually having that same impact. So, right, intention versus impact. in my mind, people saying, "Oh, just tell me whatever it is that you need," fits actually on this slide as well. I know that's also very well intentioned, but certainly it offers a lot of responsibility on the part of the person that's in need to be able to kind of organize and sort of curate that list of things and then offer it back to the person, and that's actually work too, right? So just thinking a little bit carefully about all the moving parts there, and identifying these things. The point here is just to be able to kind of say like, "Oh, that's actually," and once we can identify an emotion, once we can identify um, a reaction response, being able to think like, what's connected to that? And then what do I do about it? How can I have an action that will help me have a better experience when I hear these types of things? So just being on the lookout for things like that. So what do we do? Wanting to have, again, some things in the back pocket to use and to offer in the moment. And so we've heard the use of the sandwich technique for like feedback in an employment setting, right? You give two pieces of fluff and then some meat in the middle, and then you've been able to give your colleague or your subordinate some kind of information that they're going to be able to use in a way that feels supportive. We're going to adjust that and adapt it a little bit. And we're going to turn that into how we want to acknowledge the thing that's being said, assert whether or not that fits with what the family is needing right now, and then also just showing some sort of appreciation. So the new sandwich turns out to look like this. And there's this idea that if somebody says, "Oh, like I ran into all of these different remedies that you guys should try. You should definitely check into this because this is great. It's really going to help the patient manage through whatever these issues are." And just this idea of being able to say, and being again true to who you are as a human, and the way that you interact and interface with people. Wow, like I really appreciate that you've been thinking carefully, right? Like I'm going to acknowledge that you're trying to help. Wow, that's great that you've been looking into all of these sorts of things. It turns out actually that our medical team has a really specific plan, and we're going to be really careful to follow it. But really grateful that you have been thinking about us, and I hope that you'll keep us in mind. I hope that you'll, if that's true, I hope that you'll, keep us in prayer if you're a faith-based family, or whatever the things are that you might want to offer there. So, a new way of just thinking, okay, how can I be a kind human? This is not the only way to do that, but how can I offer information and still really maintain true, fidelity to what I believe and what our family needs right now? Certainly, this costs, right? There's some spoons involved here. And so, if you are not in a place where you can do this type of technique or have the opportunity to, sort of curate and structure these responses, better to have them in your back pocket so that you can offer them out in the moment when you don't realize that it's coming at you. But generally, being vigilant, right? Nope, this is not a time where I can do the sandwich technique. This is a time where I just need to say, like, no, thank you. Or I just need to be able to say, you know what, if you can talk to, the other, sort of caregiving adult, because I need a second, or like whatever the things are, just really being able to be vigilant about where you are in any given moment. Um, so building resilience, how do we do that? How do we start to think about what's involved? It's important to be able to think carefully about how to make these things sustainable. There's a lot of responsibility involved in trying to navigate and manage through the day-to-day sort of caregiving process. And on top of that, and any other responsibilities that one has in their life outside of that, right? And so just thinking really carefully about how to build resilience. And there's a group that has talked about these specific building blocks and wanting to think critically about how we consider those. So self-awareness, right? Having what it sounds like, knowing your triggers, knowing where you are at any given moment, figuring out, sort of what your status is. And we do that with young children. We kind of ask them like the old school, like kind of Xerox machine. That's a word that isn't used today very much, but just sort of taking a body scan, right? Like, what am I experiencing? What am I feeling right now? From head to toe, where am I? And then just thinking, of course, like, which mood am I feeling? How am I moving forward in my day? How inundated do I feel about medical things or work things or family things and all of the other elements? Being able to think flexibly, because certainly there's no way to know, right? The only certainty is that there will be uncertainty. The only predictable thing is that there will be unpredictability, right? Super rude, but unfortunately seemingly true. And so there's this idea that we can think, all right, so if and when a curveball happens, more when than if, what is my plan, rather than, oh no, a curveball's happened and I'm stuck. I can't move past that. Thinking really carefully also about how there may be some time to be stuck, and then some time to kind of create a plan. And oftentimes, if we have a plan beforehand, it helps us to be able to use it in the moment. We'll talk about that in a moment. Thinking about emotion regulation, if you're at your baseline, where is that? Where are you now? And then what helps you get back there? So if something kind of sets a family member in a trajectory that's different than what they want to be, more sad, more anxious, more scared, more frustrated, more irritable, more reactive. What is it that you do when you handle hard things that puts you in a space where you can, sort of return to your baseline, or at least approach it, right? Because we can't always get back there, but at least kind of head in that direction. And then thinking carefully about social connection. And we know that social connection is super important, and that we are naturally kind of beings that seek other beings, right? But thinking carefully about limits and boundaries, again, related to social connection, and what's too much, what's really helpful, what's useful, and thinking about ways to communicate that feel like they're true to what you're needing. How responsible are you for others' disappointment with your boundaries, for example? Um, and then intentionality, being purposeful about creating a plan. So, for the sake of, these are the last two slides here. For the sake of thinking about how we do that in society, right? Like, what are the ways that we do that? We think about fire drills. I'm from Los Angeles, so I'm often sort of thinking about like earthquake drills, which apparently is not a thing here in Philadelphia, where I live. But there's this idea that fire drills are pretty universal. So across the nation, people are thinking fires are things that are really problematic. We want to be really careful to think about ways that we handle these sorts of situations. We need a plan. And so we think about, okay, well, there should be a plan. We're going to think about how we're going to go about this. There are a lot of benefits to having a plan. It sort of reduces panic in real emergencies. When it's not a drill, you know how to proceed. Most folks know that we don't just run around screaming. Most folks know that you're supposed to be in single file. If you're in a school, there's a specific place where you're supposed to meet. All of those things are practiced when it's not an emergency, so that we have the habituated kind of element, right? We've built up this practice, we've built up this habit that now we can kind of do it on autopilot, just like driving, right? In every given moment, if you've been driving for years, you're not constantly thinking, oh, wait a minute, now I'm going to make a left turn, let me signal, let me da 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 da. Like you're doing that thinking, but you're also kind of moving intuitively. And I think that the more that we have that practice, the better it is that we can implement and employ, like, so utilize our plans. This can be thinking about how you're in a phase where there's a lot of behavioral reactivity. And so standardized behavioral management plan we know that it significantly decreases aggressive incidents, injuries, the need for physical restraint. These are things that are in place because we know through ABA, or through, you've got your behavioral team engaged, your psychologist, your psychiatrist, your BCBA, board certified behavior analyst. There are a number of different ways that we have these sort of layers, right? There's a plan, there's an agitation plan, there's a plan for aggressive behavior. And what we do is we implement that plan, and then it helps us to be able to figure out how to get someone back to their baseline in ways that limit distress, right? That limit limit destruction, and then also increase sort of adaptive functioning. So put us in a space where we can do what we need to do and move everyone forward. The hope is that the more of these plans that we implement, the more folks can de-escalate quickly, the more we can get kind of back to that baseline. So anyhow, this can also be applied to things like unpredictability with prognosis, surveillance, anticipatory guidance, thinking about any guilt around sort of genetic carrying, or powerlessness to disease progression, physical and neurological impairment. These are all, sort of things that can be fires. And then thinking carefully about, okay, well, what's our plan? What's our strategy? How do we go about approaching this? And there's studies out there that show that being, for example, this one study talks about being the mother of a child in crisis, actually required a fundamental redefining of that mother's self-identities and the work of motherhood. So it wasn't just, oh, we need to do things differently. It was that everything is different now. And so thinking carefully about how we can engage our team members in supporting the process there. So psychologists, for example, help with treatment adherence, illness coping, caregiver support, educational advocacy. The list goes on. So what is the standard operating procedure? What do we do? Well, you know that somebody implements the alarm. So what are the signs and symptoms? What do we see? What happens in the world around us when we realize, oh, it's time to use my plan? Then we think about what's the reaction response? What do we want to see people do? Like, what are the steps? What needs to happen? What would it look like in the best case scenario? And then what's our egress? How do we get out of here? How do we figure out that the way to build ourselves safe pathways to be able to get away from the thing that's bothering us, or to be able to at least manage it so that it's not taking over? And that obviously is not easy to take care of, and could involve the medical team or other parts of the community. And then thinking about, like, okay, so how do we come together? Like, what is our designated assembly area? How do we come together? Is coming together useful for me right now? And then how do I maintain accountability, which often looks like, well, what else is supposed to happen, right? How do we evaluate? How do we assess and adjust? How do we check on what we did and see how effective and useful it is? And how do we change it to give us more of what we need? So I want to leave things here and open up for questions. And I promise that was all one slide with three different, like, kind of graphics rotating in it. But the hope was that we'd be able to get to a space where we're thinking about offering enough information, and then think about how we can work together to have me target the kinds of things that you're really wondering about. So thank you so much for allowing me to be here today and to talk with you all. And I'm really looking forward to figuring out how to be useful.
Thank you so much. So helpful. As the questions for everybody, if you could type your questions in, I will read them out. I don't, Kelly, I don't see any yet, but I had some comments for you, Dr. Jones.
Sure. And I just want to throw out there super fast that there are references that we can make available. So these are some of the articles that informed what I was talking about, but I'm saving you all the journey of reading these tiny words, and can make those available if you're interested in having them.
Terrific. Thank you. I
Mhm.
was just, when you described, we've all heard like my battery's empty. I love this metaphor of the spoons. So
Mhm.
helpful. And thinking that at certain points in our journey with ALD, whether as a caregiver or as a patient, there's spoons that are, it's like the amount of spoons we have available is gone.
Yeah,
So it's that figuring out how to get more. How do you advise your
sure.
patients?
So there are a number of ways. I'm going to try really hard not to be super cliche and talk about self-care and, like, having a spa day, because that is clearly not the thing that fixes fixes. But it can buy us spoons every now and then. I actually took a second to do something that I've not done in years, and I was like, "What? Like, this is amazing!" And it actually did refill me. And so, opportunities for meditation. Truly, I mean, the sort of cathartic effect of talking to another person and getting to vent and just share what's going on, and being clear with folks, like, I'm venting right now, not looking for a fix, right? Like, not looking for you to tell me the solution, because that can be frustrating. So things like that, meditation, getting rest, like, literally, sort of pouring into yourself and being able to offer more things, being able to take some time, take a break, and be able to separate oneself from the sort of the routine or the pulls, the things that are calling on them. Doesn't mean take a whole vacation, because who gets to do that quite as often, but being able to find, like, what is going to be replenishing to me in this moment? What do I know about myself that shows me that I'm going to be able to have what I need? I spent most of today on a field with about 600 children. Good times. I was in my mom role, and I was wearing my mom hat this morning, and I was, doing a thing. I was volunteering and doing what was needed, and we were all out in the sun. And then I just realized I had to do a work thing in the car. So I took a second and I sat down in the car, and I was doing this, thing that I couldn't reschedule, and I had to be in all these places and be, there for all the folks. And then I realized, like, what do I need right now? Like, as before I got back, into the fray, I kind of thought, like, oh, wait a second, like, did I drink water? Did I go to the restroom? Like, what are the things that I need to do in order to function as a reasonable volunteer, right? Like, a reasonable mom in that capacity. And they were small, small things, but they were so important. When the whole event was over and I got home, I thought to myself, like, did I eat a meal? Like, right, like just things that I didn't even think of in the moment. And those are super small examples, but there can be even larger ones that say, I need to pull away from this leadership role. This is not something that I can balance with all the other moving parts. And it sort of thinking carefully about things more like juggling rubber balls, right? This one's going to bounce for a while until I can pick it back up versus like eggs, right? Like raw eggs. And oh, if it falls, it splatters, it explodes, and everything is terrible. And just really coming up with ways to be kind to ourselves as we figure our way through that. And I think as a graduate student, I had the egg mentality. If I drop something, everything explodes, and I don't get to, reach the end, the castle at the end, right? And learning to convert that into, oh, you know what, I didn't do that to the best of my capacity, but that's what I can give right now. And so this is a 75% job, which sounds terrible, right? Like, what? I don't give 75%. But if I give 120% to everything, like yikes, I'm not helping myself very much there.
What I'm hearing over and over with everything you say is we have to learn to pause for a second and really be aware of where we are and what
Mhm.
we can give.
And that's not weakness, right? Like that doesn't mean failure. It means actually like a really important thing. Like it means maturity. It means, like really getting to a place where we know ourselves and we know what we need and we know that we need. And I think that that's something that we don't always allow for ourselves.
It's true. And I know a lot of members in this community think the more they give, the better they are as a mother, caregiver, patient. And
Mhm.
please remind them loudly that that's not always
I
true.
will co-sign as much as I possibly can because what I've even learned, I mean, even recently I've given up. I don't have a child with ALD, but I do have, a plate of responsibilities like everyone else. And I think I've recognized like, oh, I need to be a leader in this and I need to be able to do that and I need to do all these things. And then I realize like, A, I'm not giving my full self to any of those things. And then B, I really don't need to do that in this season. That's the other thing that I thought was super cool is like, wait, maybe I can do that when my kiddo is, in high school, or maybe I can do that when my kiddo is in college. But like right now in this season, like what is my priority? And just really being honest with myself about like, yeah, this is at the top of my hierarchy. And then these things just aren't. Sorry, not sorry, but like they can't be right now.
I had somebody ask about resources while in the hospital, and since
Mhm.
you're there, what resources are there for patients and caregivers?
Sure. So in our hospital, we have long been advocating for an actual therapist. Like, so I consider myself a family therapist, right? So if I'm in a room working with like a particular patient who's a child, then that patient is certainly the assigned patient that's got the chart, right? The medical record number. But there's this whole family, there's a whole system that circles around that child. And so if we find that the sibling needs support in our setting, Child Life often offers in the moment support to siblings who are in the inpatient setting. And then they also, if the explanations of what's happening with their sibling, if they are the donor, then there are ways they offer specific support, right, for the donor. And then there are also ways that I consider myself the therapist of the child. And then I also can consult one of my colleagues if there needs to be a specific therapist of the parents or the bedside caregivers. Sometimes it's wonky if I'm that for everybody, because sometimes there's stuff that's a little bit separate. But sometimes it's a family system question. And it's how do we make sure that somebody is keeping an eye on how this whole system functions? So I'm often telling families when I meet them, parents and adult caregivers when I meet them, I'm here to also make sure that you have what you need to be able to be what the patient needs, right? And so if that means that you and I take a walk while someone else is working with the child on something, and then we do that and we talk and we figure out a plan, or we come up with some opportunities to support what their emotional and behavioral needs are as well. Sometimes families come to us with pre-existing conditions, right? So they'll that's a wonky term to use, but just for example, like a parent might have a mental health condition that they're being treated for. Oftentimes it's hard to feel like, oh, I want to leave the bedside and go and sit with somebody at the VA and talk to them for an hour. Like I can't spare that hour. I need to stay here. And so coming up with ways to use things like telehealth and like offering opportunities to be a bit creative, and building bridges with, we are right next door to an adult hospital. So thinking about building bridges there, psychiatry, so medication for different things. Sometimes we have the philosophy that medication isn't forever. But there could be a way. I'm a pretty tall person. I'm 6 feet tall. So I usually stand on a chair in session when I talk about this with folks. But I think about standing on a chair and being able to reach the ceiling. I can do that if I stand on a chair. So being able to stand in a chair, and that chair really becomes the like kind of the like these different extra resources and supports, right? So like, yes, by myself, it'd be nice if I could reach the ceiling, but I just can't. Like, even though I'm a tall person, I just can't do that. But I need to step on something. I need something to help me to get where I need to be. And I think we think of, what do we need to fill that gap? Is that psychiatry? Is it a medication for a period of time? Or is it, working with a child life specialist who comes in, sits with the patient and provides explanations, or does what we call blood soup, where we talk about like, these are the bad cells and these are the good cells. And like, this is, what's happening in the bigger sort of scheme of things. Really offering the chaplaincy. We partner with folks that are language interpreters. We partner with folks that come in for art and music therapy, dance and movement therapy. There are like many, we're, I think, fortunate to be in a hospital setting where we have all of these folks. There's nutritionists, dietitians, there are folks that work in OT and PT. And like, I have an all the T's approach. So I believe that if we can really mobilize, especially inpatient, right? There's this idea that if you're in for, a longer period of time, you have the opportunity to use those resources when it might not be super easy to find those resources in the community, or in the outpatient setting. And thank goodness many of those same folks are also available in our setting outpatient.
Well, and it's fabulous because not just CHOP provides those things. I know
Exactly.
Columbia did 20 years ago when Jack
Mhm.
was getting his transplant, and those things are available and for adults too
Mhm.
to learn to ask for help. Um, there was another question about oversharing. Now, I might be guilty of starting that Caring Bridge 20 years ago and sharing every deep, dark, ugly mess along the way. And I know a
Mhm.
lot of people with social media. Again, it's a great way to share. When is enough enough?
Mhm. Mhm.
And
And I
I
think
will
that's
apologize to Jack now.
I think it's also just, I mean, I didn't have I was actually joking with my own kiddo that I didn't have like this. Like, this was not a thing. Like, there was I'm thinking of like the Zach Morris phone from Saved by the Bell, and what our phones look like now, right? Like, it's just this idea of like this big chunky like thing versus, compared to this like super sleek thing that everybody carries in their pockets. And you're never going to have a calculator in your pocket, so you'd better learn all the steps of this math, right? Like, super funny, and we need apologies from all of our all of our math teachers. Um, we can never know what the nuance will look like, right? So we wouldn't have known when, Jack was younger, that he would be, this age, and look back and say like, whoa, hold on there, like my whole treatment trajectory is available. But I think now, when we get those awarenesses, when we recognize those things, then we start to think, oh, well, we need rules for kids with cell phones. We need, like, right, like there's just all the stuff that comes of that. And so that I think of as a natural trajectory. And I don't go about like kind of doing the blame game with, or the shame and blame, because that just doesn't get me any place. But I do love the idea of trying to kind of gain awareness and trying to figure out vigilance, and like, what is Snapchat? Like, wait a minute, and like really kind of getting to a place where we allow ourselves to be curious and then really figure things out. And now that I know, I'm going to do the thing that I'm going to do the thing that's consistent with my values. So I think, again, it's a self-assessment. Like, what are my values? What are my kiddos' values? Like, where are they with this? There are some celebrities that choose never to put their kiddos in the sort of the sort of public eye, because they've chosen to be, a public figure, but their kiddo didn't. There are some kiddos that leave having to be in the public eye and choose never to be. And there are some folks that choose to be because they want to, sort of continue to carry the torch. So I think just being really honest with ourselves, and also honest with our families about where our boundaries are. And different folks will have different boundaries, and for some people that works. And so, if every piece of their journey is cathartic or useful or meaningful or important to share, just being intentional about it and recognizing that, with that also come a couple other layers. And if I accept those layers, then this is what our family does. So I feel like there's individual differences, and I think that there's just sort of being intentional, and coming up with what feels right and what's the best fit for your family. And then as you go, realizing like, wait, nope, that's not the best fit for us. And then being able to, again, assess, adjust, and then make the pivot that you need to make that's consistent with what you need.
That's wonderful advice. I'm looking here. Dr. Jones, do you see questions in my
I do. I
chat?
see that there are 10, and I
Oh,
don't know.
I can't see them
Okay.
for some
So
reason.
I am thinking that there were some questions in the very beginning that maybe we don't need. It has to do with like, do I see people, or can we all see each other? Um, what is your recommendation for someone newly diagnosed without notice when there is no fire drill? Yeah. So like the fire is happening and there's been no prior preparation. In my behavior management life, I'm always talking to families about like, you can't give your child a timeout if you didn't explain to them what a timeout is, and like what like what the rules are, what will land them in timeout. Like you can't just come in with like this whole system and then like nobody ever knew about it. One of the things that I'm thinking about when I think about like, well, what if we were blindsided? What do we do now? Is just this idea of, here we are. What we need to design like going forward? Like what do we need in this moment? And that may not be the plan for always, but it might be the plan to get you through a particular segment of this. So it could be, okay, well, how do I sit down with a professional that understands, I'm assuming child development, but maybe that understands just sort of where the patient is right now, and what they need to know. Some of our patients, when I do consults with new patients, I always ask, how much information do you want from the medical team? Do you want to know what every medication is and what's hanging on your pole, and like what is going to happen during your transplant? Or do you just want, your parent to know that and you'll get it filtered from them? Or do you just want to sit here and trust us and sort of say like, come in here and do what you do. I don't need to know any of it, TMI, right? And I try and honor what each person is asking for. I'm definitely writing in my report what they say so that the medical team knows conversations outside the door are more important in this family's situation than explaining to the patient every tiny detail. Or nope, this patient wants to know every tiny detail, and so here we go. We need to figure out how to talk about this thing in a way that's accessible and useful for somebody who's 4, or somebody who doesn't know the medical milieu and just got diagnosed and isn't an expert at this stuff, right? So I think it really varies. I think a lot of it is, especially when you don't know, like, is this going to materialize into something that will require a transplant? Is this going to materialize into something, you know what I mean? Like, you don't know kind of what the next steps are. I think a lot of it is honesty and being like trust building. And we talk about this a lot when we have families who choose never to use, in my setting, the C word, right? Like never to use the word cancer, or never to give their child the information about what is going on. Sometimes that's tricky because, and we want families to just be aware that if they hear a nurse use that word, or if they, come across it on the interwebs, or if they, well, what is this medication used for? Oh, well, this disorder? What? Like, what does that mean? I have this disorder? Trust building and really thinking about laying the foundation work for continuing that trust is super important. So if kids learn from us that we can't talk about these certain topics, then they'll figure that information out away from us. And if that's not your value, then trying to figure out ways that we can be transparent, and coming up with ways to build trust. I think that a lot of this is done in the setting of protection, right? I want my child not to be afraid. And unfortunately, what we often learn is that folks are just then being afraid in isolation. And so it's not that we've fixed a thing that we were trying to prevent, it's that we've now created kind of a no contact zone around it. And so now we've created it as something that we can't really talk about and ask questions about and be able to really um, be working our way through this together on. And sometimes also there's a big resistance to, well, I don't know, so I'm not going to say anything until I know. And yikes, because who knows when that's going to be. And so just thinking a little bit carefully about being able to say, you know what, I don't know. Your medical team hasn't figured that out yet. Let's keep thinking about it though, because our doctors can connect with other doctors who are, right on the cutting edge of all the things. I don't know, whatever, like kind of the way that you look at it is, but we don't have an answer to that. It's just like if you're asking me, like, if I don't have an answer, I need to tell you that I don't have an answer. It just kind of like wastes everybody's time if I like vamp on some other stuff and then I don't, you know what I mean? Like it's more beneficial and helpful overall for me to admit that I don't know than to try and fill the space with weird stuff. Because when I fill a space with weird stuff, then it doesn't, I don't know that that answers our question either. It creates other problems, if that's fair.
It is. And I think also working with children for those parents that have kids going through transplant or prepping and monitoring their kids.
Hmm.
Somebody said to me 20 years ago, answer the questions that are asked.
Hmm.
And it was such an important way to think about it because I was ready to have such a heavy conversation.
Hmm.
Jack just wanted to know like little nuts and
Yes.
bolts. And
Meeting him where
then
he
and
is.
he felt so safe because I would answer anything, and his sister Anna too. But I was careful only to give the information they were
Hmm.
looking for.
Hmm. And letting them show the way. So some of this is, what we think about when we teach like preschool behavior management, right? Like if they're saying something and we answer that question that was asked to us, and then they ask us more questions. Okay, well then they're showing us that they're ready for, the next few phases in this. But if I assume that by asking that one question, it means a bunch of stuff that was never actually asked, then I kind of create a situation where I'm maybe giving them more than they're needing or more than they realize that they need in any given moment. Yeah, for sure. Okay, I see 6 questions still, and I'm hoping that we've been addressing the ones that we needed. I'm seeing many good strategies here. Thank you. That will be really helpful to families if they can begin working on them ASAP. The fire drill concept is the most valuable to me, I think. So, how can we get help, say counseling from you or pros like you from the beginning of entry into the ALD community upon newborn screening diagnosis? So, one of those studies that's in the super tiny print at the end is talking about how there's a lot of advocacy around newborn screening and how there's really an important, like when I was an intern, I was rotated with somebody who was doing like the sort of that was meeting with families who were getting like in vitro diagnoses of different types of things. And it was standard of care at that hospital that there had to be like a psychologist or a mental health professional that like was a part of that conversation. So it's not just make sure the docs are trained to be able to deliver information well, which should happen, but also let's bring in professionals that we think we can start to help this family get some exposure to, so that those folks can follow them through these processes and then they can kind of move them forward. And if they decide that they don't need them, that's different than not having them and realizing that they really had a need. So finding hospitals that believe that, right, like that have folks embedded, or asking for a referral. I kind of joke with our patients that we're a bit like vampires, and so there's this like vampire rule in lore that says that you have to invite them in, and then if you rescind that invitation, then they have to go away. So somebody like consents for me to be involved. We're a consent-based service. I can absolutely be involved if the child in the state of Pennsylvania is 14 or older, 14 years old or older. They are the person that provides the consent or the withdrawal of the consent. If there is someone who says, no, thank you, I don't really need, what you're offering. I don't feel like you need to be a part of our team anymore. We go away and we don't come back. We can work behind the scenes with the medical team. If the medical team says, well, we don't know what to do with this, so we really need your guidance. Like there are ways that we can kind of stay involved peripherally. But if the family says, no, thank you, then we go. And so really trying to be an advocate and saying, look, I really would love to have a mental health professional involved on our team. How do we do that? Is that the social worker? Is that the psychologist? Do we need a psychiatrist? Like kind of what are the different levels of care? And we even have consultative services like the BCBAs, the board certified behavioral analysts, who can come in, set up a safety plan or a behavior plan, and then the team will follow that plan, and then they kind of come out, so they don't have to stay on the team the entire time. And I often think of myself as someone who kind of wants to be fired, right? Like we do the skills, we come up with a way to execute the plan, and then you take it from here. And if you need us to stay, we absolutely will. But if what we're doing, the idea is to give you the skills and the strategies and techniques to do the thing, and then if we're not necessary, then we don't have to continue to be a part of the care. So I think, and it's exciting, right? It's like a graduation from care rather than it being a termination of care. Um,
And for those people not affiliated with a hospital,
Fair,
I
very
often
fair.
recommend like
Yeah.
psychologytoday.com or therapy.com. You can put
Hmm.
in your insurance, you can put
Hmm.
in what you're looking for,
Right.
and we can find someone, in your area.
Hmm.
There was a question here I thought was interesting. I know you work with children, but Sue Black had asked, she's the mother of an adult son with
Sure.
men
Hmm.
and trying not to be a helicopter mom. What do you
Hmm.
think?
Yeah, I'm seeing it now. So I think there's constantly this kind of period of time where, so again, when I was an intern, I worked in sort of a diabetes team where I had an opportunity to exposure to a lot of things as an intern. I had an opportunity to definitely onco and the things I do now, but other things too. And I think when I had a chance to work with diabetes population, folks that are diagnosed with type 1, there's this idea that the teenagers are going to need to do their blood sugar checks, right? Like there can't be this way that like the adult kind of keeps coming in and saying like, let's check your sugars every single time because like it has to happen multiple times during the day and like you can really only do so much there, and there has to be this like transfer of responsibility is my point, right, where there's this opportunity to say we are here to guide you in the same way that you would with like any sort of adult developmental thing, right, like being able to take the car out or driving themselves to school or being able to go on a trip without the parents, or when you figure out that they're developmentally appropriate for that. It's a lot of these kinds of like fits and starts of like trialing something and then the child showing that they can rise to that level of responsibility versus that they are needing a bit more sort of scaffolding, right? Scaffolded support. So being there for the things that it looks like are really needed and then scaling back for and truly that scaling back part feels encouraging, right, to the autonomy and independence development of the sort of the young adult, the teenager, any person. And then because I can see that this person trusts me to do what I need to do. But then if there's times where it's like, wait, hold on, like we've reached the A and C of the wrong, the A1C. Sorry, A and C is all of my all of my day to day. But the A1C is doing something that we don't need, and now you're at risk. Like, hold on a second. Like, we've got to figure this out, or we need to come up with a new strategy. We need you to wear we need you to wear a pump. Like what are the other savvy ways that we can go after this that give you autonomy and that don't have us have to hover over you, but that's still, and I don't know what the pump equivalent is in this situation, right, but like coming up with ways to collaborate with the medical team around like these regular check-ins and like where are things, and again assess and adjust if you're at a place where you feel like, oh, like this is, yeah, you're doing the things, you can have your autonomy, but then like, oh, wait a second, like, nope, I need you to go back to traffic school because when you run these red lights, you can't, like you can't keep doing that. So coming up with ways to really just sort of have it be a behavioral contingency. You put X into the machine, you get Y out of the machine. And these are the ways that we get involved or not involved based on how much you show us that you're able to do in the way of your own responsibilities. I hope that's fair.
I think that's fair. I think it's also a good opportunity to use that sandwich technique to have a
Mhm,
difficult conversation with
mhm,
your son about how much you love them, how wonderful they are, and you've got concern, add the meat in the center.
mhm, mhm.
Um, it
Yeah.
is tricky with adult children, right?
Mhm. Yeah. I'm seeing a comment. There are three comments left from the same person, and I see the more recent ones talking about like what to do without healthcare. And I think so. I want to say things without getting fired, right? I know that our sort of climate has changed around, sort of availability of healthcare for folks that don't have like kind of, like medical insurance. And I would love to say that there are more programs coming online around targeting folks that are needing, sort of specific support, even without insurance. And I think there are hospitals that kind of have like there's a hospital I worked in California where I'm from that just kind of said, look, we support families regardless of the ability to pay. Like we are here, we are serving this community, and we are doing the things. And that is lovely and not always available every place, but being able to really tap into, advocacy and resources that can offer care even when, like kind of, and some of that can come from social workers like in our setting who seem to know all the things and have access to, sort of programs that will help people pay their rent or their, like kind of or their electricity bill, or like there are ways that folks are getting support. It's more about like kind of being being able to ask the right folks and then also being able to consider access to resources. So using entities like ALD Connect and others to be able to say, okay, well, how do I get to this thing that I feel like I need? If I don't know if this is appropriate use of ALD Connect, so don't get me, I'm not trying to get you all in trouble here, but wanting to be really clear about like, well, where do I go if I can't, sort of use this other, and even to be honest, my kind of prior work before I got into oncology was in the world of ADHD. And so thinking about, well, how do I get a diagnosis of an attention, sort of concern? My child is struggling. They need their IEP. Like, what are we doing? And really, a person's own pediatrician's office is often a place where we will refer people back to. So we will frequently say, have your pediatrician give you some information about like who the people are that you can check in with about this, so that we can get you, the right kind of services and match care to what you need. And in our setting, we have wonderful opportunities in the primary care space where there are psychologists embedded in primary care. So just like they go in and see the pediatrician, a psychologist goes and sees folks in the pediatrician's office, as a matter of convenience, but also a way to get folks in the community care that otherwise wouldn't be readily available.
Well, I would like to thank you from the bottom of all of our hearts. This was so well done.
Oh,
You
thank you.
just provided a huge amount of information, and I thank you all for attending today. Thank you,
Brilliant. Thank you so much.
ALD Connect, and thank you, Dr. Jones,
Of
again.
course. Definitely. Take good care.
Thanks.